We were talking about pregnancy bleeding and looking at the 3 trimesters. And this is where we ended, looking at the 3rd trimester. We'll take a look at each one of these in a little more detail. So if we look at placenta previa, look in your textbook where it describes the different degrees of placenta previa. The degree to which the placenta covers the internal cervical os is estimated in percentages. So when we say internal cervical os, os is opening, so the internal cervical opening, remember the cervix is about 2 inches long and thick. So we're talking about where it opens from the uterus, not from the vagina. First you have the low-lying placenta, and that's just where the implantation is in the lower portion of the uterus. And some of these, many of these I should say, low-lying placentas that start out that way in early pregnancy end up not being low-lying later. As those muscle fibers stretch, they actually pull that placenta up. Not that the placenta picks up and moves, but the upper uterine segment stretches with those muscle fibers actually pulling and elongating, and that's what actually brings that placenta up. And then we have marginal implantation, where the placental edge approaches the cervical os, so it's just marginally touching it. Partial placenta previa, where that placenta occludes a portion, and that can be in different amounts of portions. Or you have total placenta previa, where the implantation totally obscures the cervical os. Now with these last 3, it always indicates a cesarean section. You cannot deliver the baby through a placenta previa. The incidence is about 3 to 6 in 1,000 pregnancies, but that incidence does increase with increased parity, advanced maternal age, any past C-sections, multiple gestations, and past D&Cs. Remember anything, well, first of all, the placenta will never implant in the exact same place again. So if all the good places have been used up, like with multiple gestation or increased parity, that fertilized ovum keeps tumbling down further and further into the uterus, increasing the chance of placenta previa. And then the past C-sections or D&C is because any scarring of that uterus is also a place that the placenta will not implant over. Now there could be many nursing diagnoses. I just throw this one out here. Fear related to the outcome of pregnancy after an episode of placenta previa bleeding. Remember with placenta previa, it's bright red, but painless bleeding, but bright red, and it can be a lot because remember those placental blood vessels are huge and they're right over the cervical opening, and therefore there can be a lot of bleeding, so it can be a very scary situation. The nursing care and management, most placenta previas are diagnosed before they ever have symptoms, before they ever have that bright red bleeding, because we do so many ultrasounds nowadays that we can see where that placenta actually is. So it doesn't present usually with symptoms, although that can happen, but most of them we know ahead of time. We have to evaluate for patient history of it, and we always assess for that painless bright red vaginal bleeding, and it can stop as abruptly as it began. Try to estimate the blood loss, get her vital signs because you want to see if they're indicating loss of blood, and there is a test that can be done in the lab called the Kleihauer-Betke test, where they can determine if the bleeding is from the mom or the baby. Never, never, never attempt a pelvic exam whenever there's vaginal bleeding. The only time you would do that is if the physician is standing right next to you and you are all prepared to go do an emergency C-section. Assess other labs like hemoglobin, hematocrit, etc., and assess fetal heart tones to see if the fetus has been compromised from this blood loss. Treatment is immediate bed rest. Get her off her feet. Use gravity to your advantage and get her off of her feet. Do external fetal monitoring. We don't want to put anything into the vagina to cause more bleeding, so we'd never do an internal, but we need to monitor this fetus. If we don't have an ultrasound, we were going to get one to determine placental position, apply oxygen, because that's the fastest way to get oxygen to the baby, give it to mom by mask, get an IV access in case we need it for emergency meds, and assess her for hypovolemic shock and assess her for preterm labor. Now, not all placenta previas have to be delivered immediately. If you get her on bed rest and the baby heart tones look good, mom's vitals look good, there's no sign of infection or hypovolemic shock, we can take it a day at a time as long as she's not in labor. We can take it a day at a time before we actually have to deliver her. Every day that baby is inside is a good day. Okay, the thing to remember is that anytime you have a placenta previa, then postpartum, these women are at a greater risk for hemorrhage because usually, well, not usually, always, the placenta previa means that you've got an implanted placenta in the lower uterine segment. And remember how the upper uterine segment stretches and grows and those muscle fibers actually elongate. That does not happen in the lower part of the uterus, so it doesn't contract as well as the upper part when you want the uterus to be contracting postpartum and stopping the bleeding. Another thing to keep in mind is that the uterine blood supply is less in the lower uterus, so the placenta tends to grow larger there because of that. And then when the placenta is delivered, it leaves a larger denuded area, which can cause maternal hemorrhage because you've got a bigger area that can bleed from and that uterus that's not contracting there. So women with placenta previa in pregnancy are always at a greater risk for postpartum hemorrhage. Keep that point in mind. Okay, then Abruptio Placenta. This placenta is implanted correctly in the right place in the fundus, but it suddenly separates prematurely. It usually occurs when it does around 20 to 24 weeks, but it could be as late as the first or second stage of labor. So second stage of labor is when mom is pushing, and it could actually occur, then. If it happens earlier than 20 weeks, it's considered a spontaneous abortion. The real primary cause of abruptio placenta is unknown, but there are some predisposing factors that we have seen. Women of high parity, women who already have chronic hypertension, women with PIH, pregnancy-induced hypertension. Anytime there's a major trauma, she's at a greater risk. And then vasoconstriction of the blood vessels of the placenta from cocaine use or smoking. Different degrees of separation. Obviously, grade 0 is the mildest. Grade 3 is the most extreme. I will not ask you a question to identify whether this particular situation is a grade 2 or a grade 3, but just know that if they talked about it in a scenario, for example, you would understand that a grade 3 is the worst. And this is where maternal shock and fetal death will occur if we don't have immediate intervention. And that's why an abruptio placenta is always an obstetric emergency, and it requires an immediate C-section. So we just hope that that abruption occurs when she is in the hospital and not out in the community. The nursing assessment here, we can differentiate this from the placenta previa, because with placenta previa you have bright red bleeding and it's painless. But with this abruptio placenta, you have sharp stabbing pain, and it's usually very high in the abdomen because the placenta has just pulled away and it's in the uterine fundus. So as that initial separation occurs, you have that very sharp stabbing pain, and then they'll have pain with each contraction or just the very severe pain continuously. Now, how about the amount of bleeding? Well, they don't always bleed. Obviously, if that placenta pulls away and the edges have separated, there is going to be bleeding. But sometimes the total edge of that placenta all the way around is still implanted into the uterus, but the entire inside of it from that edge all the way across is separated. And so the bleeding builds up behind that placenta into the uterine muscle. And that's when they get a hard, board-like uterus, because that blood infiltrates the uterine muscle. And remember, I mentioned in class, anytime you see the word board-like, firm, board-like, you know there's some blood there somewhere, no matter what the situation is, pregnant woman or not. Check the labs. We want to check her hemoglobin, her fibrinogen, type and cross-match her, because she's going to surgery and you're probably going to need to give her blood. Assess her for signs of shock, and she's always at risk for DIC because her reserve of blood fibrinogen is used up because her body's attempting to accomplish some clotting, and therefore they're at great risk for DIC. And again, assess fetal heart tones to see how the fetus is tolerating this situation. We're going to give her O2 by mask, monitor her fetal heart tones, get IV fluids going, maybe blood. We need to replace that fluid. Always position her on her left lateral side. That's going to prevent pressure on the vena cava, which is going to further compromise fetal circulation. No vaginal or pelvic exams, no enemas. We don't need to stimulate anything more. Kind of the rule of thumb is whenever you have a woman who comes in with bleeding, you do not do any pelvic or vaginal exams. And if that delivery is not imminent, like she's crowning and delivering right then, she's going to have an immediate C-section. Okay, let's look at the prognosis, because this is an obstetric emergency. When we look at fetal prognosis, it really just depends on the extent of how much of that placenta separated and how much fetal hypoxia has occurred. When we look at mom, it depends on how fast we got treatment started. Women can die from massive hemorrhage, shock, and circulatory collapse, that DIC, and then renal failure because we don't have enough perfusion to the kidneys. So prognosis for mom and baby is certainly a huge challenge, and we hope that we can catch it quickly and that prognosis will be okay, but babies and moms do die from this if not getting immediate care. So take a look and compare and contrast between placenta previa. Where is that placenta located? What's the character of the bleeding? Is there pain or not? What's the uterine activity like? Placenta previa, there's no uterine activity at all. In abruptio placenta, that uterus is firm and board-like. How do you diagnose it? And look at the therapeutic management. So take a look and be able to differentiate between those two if you had a scenario describing a situation. So we'll talk about these questions in class. What are the essential elements to include in patient teaching for that woman who has a placenta previa? We're going to be talking mainly about the woman we send home with it. And what are the nursing measures and rationales to promote maternal and fetal oxygenation in any hemorrhagic disorder? So keep those questions in mind as you are progressing through this unit. The last type of bleeding in the third trimester is preterm labor. Now the definition of that is any labor that occurs before the end of the 37th week. About 9 to 10% of all pregnancies have some preterm labor, and preterm labor is always considered serious because if we don't stop it, it could result in a preterm birth, and then we have a premature infant. And premature infants account for the vast majority of neonatal deaths in the first 28 days. So 2/3 of all infant deaths. Now the cause, it is associated with dehydration, UTI, and chorioamnionitis, and that's an infection of the fetal membranes and fluid. Usually infection is some sort of a culprit there. Women may not even know that they have an infection. So with a dehydration, when they get dehydrated, the uterus gets irritable and cranky and it starts contracting. So we want to hydrate her. And good teaching to stay hydrated in pregnancy. The UTI, any kind of infection in that urinary tract, think about the urinary tract location and where it is located in relation to the uterus. So if you've got an irritated, angry urinary tract because it's infected, it's going to make that uterus irritated and angry, and it's going to start contracting. So we need to hydrate her and prevent UTIs. Or treat them right away. So anytime we have a woman who comes in to the labor area in preterm labor, we're going to start an IV to give her hydration and push fluids, and we're going to get a urine specimen to evaluate for UTI. And then she may get some antibiotics if we have identified an infection. Symptoms of preterm labor, often they don't have real strong contractions. They just might have a persistent, dull, low backache with some vaginal spotting. It's not always bright red, but it can be. They feel pelvic pressure or abdominal tightening, and they might say they feel kind of like menstrual-like cramping. They can have an increase in vaginal discharge, and they can actually have uterine contractions or intestinal cramping, like they have to have, like they're going to have diarrhea or something like that. So we'll look at this case study. We have a patient at 33 weeks saying she thinks her water broke. This is her 4th pregnancy, and 2 of her infants were preterm, and she had 1 elective abortion, and she has had regular prenatal care. So we're going to talk about what would be the most important assessments that you, the nurse, should make in this situation. And continue then to look at this data. Small amount of cloudy fluid draining from her vagina. A Fernie test is positive. We have her vital signs. We have the fetal heart rates. And she has some occasional contractions. So we want to say and look at what data from those previous assessments are most relevant. What is the main judgment you would make from this data, and what's the basis for your judgment? And would you perform a vaginal exam at this point? Why or why not? So think about that. Here's some nursing diagnoses, again, not all inclusive, but some that you might think to include with preterm labor patients. Another case study here we'll look at is a prima gravida, admitted to the birthing center. She's only 27 weeks. She's in probable preterm labor, and her membranes are intact. We have some physician orders here, and we'll have you look at which of these orders has priority and why, and what position should we put this patient in and why. Remember, why, one of the most important questions we can ask in nursing care. And then we're going to give her some mag sulfate and look at the fact that her contractions stop, and what kind of teaching do we need to impart with her before she goes home on this medication, and any other additional teaching. We'll look at our interventions. She needs to be on bed rest. Again, use gravity to your advantage here. Get her off of her feet to relieve pressure of the fetus on the cervix. We're going to continue with IV fluids for a while to keep her well hydrated. And also vaginal and cervical cultures, urine specimen, because we want to rule out any infection there. We'll use tocolytic therapy to halt her labor if needed. And if we cannot stop the labor, we're going to give mom betamethasone. This is a steroid which encourages fetal lung maturity. They may or may not do an amniocentesis to look at the LS ratio to see if the fetal lungs are mature. Remember, that's the lecithin and sphingomyelin ratio. It's supposed to be 2 to 1. Monitor fetal heart tones and monitor uterine contractions. And this is where we're going to stop this recording, and we'll pick up part C with hypertension in pregnancy.